Hello, I am Dr. Pawan Gupta, eye surgeon and retina specialist. Today we will be discussing a case of multifocal IOL exchange where main problem patient was suffering was halos and glare, and this surgery was performed 2 years back. Patient also had Yag Capsulotomy and pupil was also non-dilating. So as you can see that we are trying to dilate little bit of pupil with the help of phenocaine. It dilated a little bit, and another challenge in this case is apart from that patient has capsulotomy, that this is 2 year old case and anterior capsulotomy is also very small. So first we are trying to enlarge or disengage the lens from the anterior capsular margin. This, and now we are trying to enlarge the capsulotomy so that it will be easy to take out the lens from the bag. So this is your, so as this case is roughly 2 years old, so the capsule is pretty thick and it requires a lot of force. So this is, we are enlarging the capsular axis. So now this residual attachment we are cutting with micro scissors because there is a risk that rhexis might extend. So now the capsular axis, the anterior capsular margin is enlarged, and now again with the help of a spatula we are trying to make sure that anterior capsule is free from the lens. So this is done all 360 degrees just to make sure, as the case is 2 years old. Now we are injecting viscoelastic behind the lens. So it will again ensure that the lens is pretty much free from the capsule. So now we are trying to take out the lens out of the bag. So as the case is pretty old, 2 year old, this haptic is pretty much adherent and is difficult to take out the haptic. See how adherent it is. So with the help of this second instrument, the Y pusher, I am trying to stabilize the capsule and trying to just pull out the haptic which is stuck, but it is very much adherent. So now we have decided that we will cut this haptic, because if you try to pull it out too much, the bag might get damaged. Now we have cut the haptic. now we are trying to take out the second haptic out of the bag. So this was relatively free. It was not badly adherent, and a little bit of dialing, this haptic is out of the bag. So now once lens is out in anterior chamber, we will cut this lens into two parts with the help of this vanas. So now this we have cut the lens into two parts, and we will take out one by one. So now this is the first part we have taken out with that main incision, and second part is also out. So once lens is out, as there was Yag Capsulotomy, so there was little bit of vitreous that was coming out. So we did vitrectomy to make sure that there was no vitreous strand in anterior chamber. So vitrectomy, we are doing vitrectomy here. So we are trying to cut all vitreous strand that is possible. So when we are going with the cutter under the iris, at that time we are not using the cutter. It is only we are using. So see here, this the vitreous is attached, and we are trying to see this. The vitreous strand is there, and so now it is free. So once we are sure that we have removed the vitreous from the anterior, I am staining it with Canacord just to be additionally sure that there is no vitreous strand. Now see, with the staining of Canacord, there was another residual strand. So we'll remove this vitreous strand. So once your anterior vitrectomy is done, so now I am implanting intraocular lens. So first I am opening the lens over the iris, as there is no posterior capsular support. So once this lens is open in the anterior chamber, so now I will be placing the lens in the sulcus. So this haptic is gently placed behind the iris, and with the help of the Y I am just making sure that it is at the right place. But I think this is behind the capsule, so we'll be replacing. So I have bought this haptic again over the iris, and again I have repositioned this haptic so that it goes into the sulcus, and with gentle dialing of the lens. We have placed the IOL in the residual capsule is pretty tough as the case is already 2 year old. So the lens is stable in the sulcus. So now once this IOL is stabilized, we are just removing whatever residual viscoelastic is there. And once viscoelastic is removed, our we'll just close the section with the hydration, and surgery is complete and lens is well centered. Thank you.